Good morning, good afternoon, and good evening to everyone joining us today as we gathered from all over the world, from different time zones. I would like to extend a warm welcome to each of you. Welcome to our PUSEN webinar, our suction devices and technical advances, the future of endourology, RIRS leading the way. I'm Kasia Korab from PUSEN Medical, and it's truly wonderful to see such a distinguished group of professionals and experts here. First and foremost, I would like to offer a special thanks to our course director, Professor Somani, and to our faculty members, Dr. Martinez, Dr. De Coninck, and Dr. Luk. We are really honored to have your expertise guiding us today. And as we embarked on this journey of shared knowledge and experience, I really encourage everyone to actively participate in the discussion ahead. Our agenda is filled with topics in the endourology. So let's approach today's learning with open minds. And well, thank you all for being here. And may this be a really fulfilling and engaging session for everyone. Voice over to you, Professor Somani.
Thank you very much, Kasia, for your kind words. I'm very thankful to you, Wendy, and the whole team PUSEN for organizing this webinar, because suction is a very, very hot topic currently, and there's a lot of debate everywhere we go. Very, very thankful to the group. So Vincent, welcome from Belgium. Begona, welcome from Spain, and Angus, my colleague from UK. So it is a great pleasure to introduce the concept of suction devices and some technological advances. And is this the future of urology, and where does RIRS or retrograde intrarenal surgery stack in this? I know we've got a lot of participants here on Zoom, but also welcome to all the participants and other faculty members and guests who are listening in China through the other portal. And with that, I will hand over for our first speaker, which is Dr. De Coninck, for speaking about intrarenal pressure and temperature, and is it the new frontier? Over to you, Vincent.
Thank you very much, Bhaskar, for this nice introduction. And of course, I would also like to thank PUSEN for having me here and to give a presentation about intrarenal temperature and pressure. Normally, you should all see my full screen now.
Yes, please go ahead.
Okay, thank you. So in the next 15 minutes, I will talk about what do we know about temperature and pressure, what do we have, and what do we need in the near future. What do we know about pressure? Well, the physiological intrapelvic pressure is between 5 and 10 centimeters of water, which equals 4 to 7 millimeters of mercury. What we also know is that the threshold for biliovenous backflow is between 40 and 60 centimeters of water, which means that during the intervention, we should try to stay below this limit. However, from studies, we know that it's quite easy to go above this limit. And with handheld pumps, you can increase intrapelvic pressure up to 300 centimeters of water. With these high pressures, there's a higher risk of complications, including bleeding, hematoma, urinoma, sepsis, and postoperative pain. So therefore, what we generally recommend in practice is that when using irrigation, using just gravity and having this irrigation back at the level of 40 centimeters of water. Without manual pump, then the intrarenal pressure will never exceed this 40 centimeters of water. And what you always can do is using this manual pump, but use it very, very gently. When the vision is not good enough, or when there's a small blood clot, or you want to clear the vision of dust, then this manual pump can be used very gentle. What do we know about temperature? Well, 30 years ago, there was a study that found that maintaining a temperature of 40 degrees of Celsius for 2 hours results in cell death. Based on their findings, they created or they developed a T43 equivalence as a metric for thermal tissue damage. And they found that when having temperature of 50 degrees of Celsius for approximately 1 minute, this also results in thermal tissue damage. And when the temperature is 56 degrees of Celsius, within 1 second, you will have thermal tissue damage. So for this reason, in general, it's recommended not exceeding the limit of 40 degrees of Celsius during an intervention. The temperature depends on the total power that you're using. And when exceeding this temperature, the cell death will in the end result in strictures, as you can see at the left side, or this can also result in spontaneous renal bleeding. What do we know when we're talking about power? You should know that this is a product of energy and frequency. The higher the power, the higher the intrarenal temperature will be. And as you can see, for a low power of 5 watts, temperature will nearly not increase, but for higher powers of 40 watts, you can see the temperature easily increases from 30 up to 50 degrees of Celsius, even with a good irrigation. The second graph is an important one as well, since this shows that people who are using intermittent laser activity gives the opportunity to the liquid to cool down when the laser is not in action. However, during continuous lasing activity, you can see the temperature will continue to increase. And the last graph that I absolutely want to share is this one. This graph shows that for one specific power, not using irrigation easily increased temperature up to 80 degrees of Celsius, while having a very good irrigation of 15 mL per second or even 40 mL per second, this will not influence temperature. Last but not least, it's also important to know that one laser is not more dangerous or safer than the other. And as well, there's no difference whether you're using a very small fiber of 150 micron or a bigger fiber of 200 or 270 micron. So based on these findings, what we generally recommend is that the total power should always be taken into account during stone lithotripsy. During the treatment of ureteral stones, in general, we do not recommend exceeding 10 watts and 15 RIRS, since there's a limited space and irrigation flow rate is limited as well. In the kidney, you can increase power up to 20 or 25 watts while maintaining a good irrigation flow rate. However, we also know from studies that when you exceed these thresholds, this might lead to direct lesions of the ureter, as is shown here, and especially at the right side, you can see many burn areas that in the end will lead to the formation of uteral strictures. Therefore, it's important to know that the high power lasers that are available nowadays are not essential at all for flexible ureteroscopy. It's nice to have them, but please remember that you do not need it for the treatment of stones. These lasers were developed initially for the enucleation of prosthetic tissue. And of course, you can also use them to speed up procedures like PCNL and bladder stones. Then it's interesting to have a little bit more of power. But for flexible ureteroscopy or semi-rigid ureteroscopy, they are not necessary at all. And of course, they have some nice features like pulse modulation effects. So you can use them when performing ureteroscopy, but please use them with care. Because if you're going to use them as a high power lasers and use very high powers, then sooner or later you will get in trouble, as shown in this video. Moreover, there's a nice study that showed that an ablation plateau occurs after only 15 hits, which means that when using 15 hertz of frequency, you need to move the laser fiber all the time. They also performed some studies while moving the laser fiber, and then again you can see in this graph that even while moving at 1 millimeter per second or even 3 millimeters per second, at one point, in the end, you will reach an ablation plateau. So in the end, there's not a big advantage of using high frequencies. The question should not be how fast can you go with this laser, but it should be how fast should you go. And I think you can go fast when you're remaining or staying efficient and safe. Safe means not exceeding the total power of 10 watt in ureter and 20 to 25 watt in the kidney. But efficient means to be able to perform non-stop lasing while targeting the stone and maintaining good visibility. And this is shown in these videos, in which you can see the difference between low frequency lasing and high frequency lasing. The difference between the left video and the right video is that at the left video, there's no usual access sheet, and at the right video, a usual access sheet was used. The difference is that when using a sheet, of course, the drainage will be a little bit better, so the dust will be cleared much more easy, so the visibility will be a little bit better at the right side. So first we started at 5 Hertz, and everything is good. I think the visibility is quite okay. Now we are using 10 Hertz, and the dust is impairing a little bit of vision, but it's still okay. But once we increase the frequency to 20 Hertz, you will see that the vision will become impaired, especially when not using usual access sheet, and that I needed to stop from time to time in order to clear the dust. I was not able to perform non-stop lasing at the left side. So for this reason, I don't think that you really need these high frequencies of high power lasers for stone lithotripsy. And this is also nicely shown in this paper that was published 2 years ago. They compared low power with high power lasers, and they found that in the end, when using a high power laser, there's a higher total energy at the end of the intervention, but there's no difference in lasing duration, operative time, ablation speed, and stone-free rates. The second question that I would like to address is, what do we have? Well, for pressure, we have several devices to measure pressure, including a guide wire, including special catheters, and there's also a ureteroscope that is able to follow pressure during the intervention. However, this ureteroscope is not yet available in Europe. What do we have to record or monitor temperature? Well, again, there are some guide wires, but also there recently disposable flexible ureteroscope has been introduced with a temperature sensor. Of course, we also have ureteral access sheets, and we recently performed a review and a systematic review about the advantages and disadvantages of ureteral access sheets, and in fact, they do not that much. The only thing that they do is improving outflow and decrease in intrarenal pressure for the same irrigation inflow. However, it's important that if you further increase inflow by using a manual pump and using this not very gently, then even with the ureteral access sheet, you still can cause high intrarenal pressures, and this might result in fornical ruptures, as you can see in this video. When using a sheath, then it's important to keep the ratio between the flexible ureteroscope and usual access sheet diameter below 0.75 in order to have enough drainage. And using the sheet might in the end result in a decreased pressure between 57 to 75%. The second advantage of ureteral access sheet is because of the better drainage, the temperature will be lower as well during lasing activity. And this is nicely shown in this graph. All other things that people are talking about ureteral access sheet protect your ureteroscope or shorten the irrigation time or might lead to improved stone-free rates are not proven at all as well. There's no clear difference in terms of complications, whether ureteroscope sheath is used or not. So in conclusion, I think it's a nice tool, but of course, I don't think that it should be a systematic step during flexible ureteroscopy. Personally, I use it when there's an increased risk of infectious complications or when the visibility is really low during intervention and I'm creating a lot of dust. Then to improve outflow, it might be interesting to place one. Of course, as Bhaskar said, the suction is getting more and more interest in flexible ureteroscopy. So we also need to spend a little some words about suction ureteral access sheaths. There are some studies, and this study found that ureteral access sheath with suction improves the immediate stone free rate and stone free rate at 3 months. The operative time was shorter, and that there was a reduced risk of complications and fever. There's also a very recent meta-analysis that compared traditional with suction ureteral access sheaths, and again, they found better stone free rates, less complications, less postoperative pain. So this seems to be promising. And to conclude this presentation, what do we need? Well, we need some more research on the existing technologies. I think that further investment or development of downsizing ureteroscopes is of interest, since this will in the end improve the outflow, and this might result in decreased pressure and temperature related complications. More studies are necessary on suction, including direct in scope suction, fans, and suction ureteral access sheaths. And last but not least, we need sensors in order to sense real-time temperature and pressure. So in the end, I think that we need sophisticated self-regulated suction device with integrated pressure and temperature monitoring and aspiration technology. And I would like to focus on the word sophisticated. It should not be just a self-regulated suction device, since when, for example, you're performing a flexible ureteroscopy and the pressure is okay, but at one moment you're causing a fornical rupture, then this might lead to reduced pressure because of leakage into the perirenal space. So for this reason, this kind of machines should be intelligent or sophisticated in order that this kind of abnormalities might be noticed as well during an intervention. This is the first study that I found using this kind of device. So it's an irrigation suction platform while using a temperature pressure regulation. And the first study found that this is very promising and seems to be work in an accurate way. So we absolutely need more studies in order to evaluate this interesting technology. Thank you very much for your attention.
Thank you very much, Vincent. That was really a good overview of both suction, pressure, temperature. Wonderful. I'll just ask you one question before we move on, and also to the audience who are listening, and to our Chinese friends who are listening in China through a different portal. Please, if you want to ask questions, put it in the chat, and we can take questions here and answer them. Vincent, there's so many parameters to look for. If you had to pick out one, between pressure, temperature, and suction, which is the parameter you'd pick out? I know they're linked in some way, but which is one thing that you think will be most important?
I think rather temperature, because during the intervention, we have no idea what the temperature is during the intervention. And sometimes we are working at 20 watts, but we want to speed up the procedure. But then I don't really dare to, because I might be afraid that the temperature might be too high within the kidney. Of course, pressure is important as well, but pressure might be controlled a little bit better because of when you're using this gravity bag without manual pumping, you know that it won't be too high. And second thing is when you're causing high intrarenal pressure with fornical rupture, this can be seen immediately during intervention. From time to time, I really focus on the transition of the fornix and rest of the kidney. And when you see that this very small space, as I showed as well in the video, is not bleeding and it seems to be normal, then I know that there was no high intrarenal pressure. However, when you start seeing these kind of fornical ruptures and it is bleeding, or there's just bleeding during intervention, you did not touch the wall with a laser fiber, then probably there was a high intrarenal pressure. So if I could choose, of course, I would choose both, but if I really should pick one, then probably I would go for temperature.
Okay. Thank you, Vincent. That was, yeah, I think I'll just finish off quickly, but I think temperature is hidden. You can't see it. And the effect, if you get ureteric stenosis, is much more devastating. Everything is important, but I agree. Because it's a bit hidden, it's the least that you know of. Yeah. Mm-hmm. So with that, I will hand it to Begona. Thank you so much, Begona, for talking about suction cystoscopes and why it is a game changer. Over to you.
So, thank you so much, Bhaskar, for this invitation. Thank you so much, Cassia. Thank you so much, Wendy. Thank you so much, PUSEN. And thank you, everyone, for joining. Let me introduce myself. For those who don't know me, my name is Begona, Dr. Ballesta Martinez. I work in Spain, and I'm going to talk about the suction cystoscopes in endourology, why they may become, if they're not already, a game changer. So, the technology, the PC200 cystoscopes by PUSEN. It is a 15 French cystoscope. It has an amazing resolution, very nice HD screen, and the unique feature that it brings is that it has this button, the little blue thing that you can press while you're operating, like in the ureteroscope, connected to your vacuum device, and during the procedure, you can use the suction. It comes with a 7.2 French working channel, which is very wide, and it is straight. This is very important. It comes with this T-type connector, and as it is straight, it is very convenient to insert instruments. The deflection with the working channel free is 210 degrees, both upwards and downwards, leading to a field of view of 90 degrees. Of course, with the fibers in, it's reduced, but it's still working. Look at the with the 550 fiber, it's still deflecting. So, what advantages does it have for cystoscopy? The indications for cystoscopy with these video cystoscope with the ISS are the same as with any other cystoscope. Diagnosis of hematuria, diagnosis of lower urinary tract symptoms, removal or insertion of stents, all the same indications. But what it brings is that it has important advantages that may make your life much easier. It's very, very easy to handle. It's light, it's very portable. It's 100% sterile, 100% warranted, because it's single use. Also, the visual quality is very, very good. You can record all your procedures and it's fully digital, and there's no maintenance, sterilization, no preparation. You just open the bag and use it. And this is very important because cystoscopy is a procedure which is done in every hospital in the world daily to many patients. So if you decrease the time of preparation, in my hospital, for instance, in my center, we have a washing machine which takes 25 minutes. If we save those 25 minutes, we could reduce the waiting list by doing much more procedures per day. Also, it reduces infections theoretically by the suctioning and by the suctioning and by the single-use properties. And infections are very, very important. in cystoscopies. Cystoscopy is a procedure, as I said, as we all know, is very common. And UTIs have been described in up to 10% of procedures. This is a lot. So if we can reduce them, we will make a difference. And this, besides all these advantages, we have the direct in-scope suction, which improves outcomes significantly. Visibility may be improved thanks to the suction. If you have dirty urine in a normal cystoscope, maybe you have to reschedule the patient. Whereas with this suction property, you don't need to cancel. And canceling a procedure is important because it may be a Clavien-Dindo 3A or B, depending on the anesthesia type, but it's a Clavien-Dindo 3 complication because you literally need to repeat the procedure. So this is very important. Also, it's very convenient for cytology sample collection because with the suction button, you don't need to plug any device, you just get the sample. And for bladder tumor treatment with laser or bladder stones, it is very convenient. It has a very, very nice deflection, and thanks to the suction, you can have the bladder full as you want, at the exact level you want, and with very, very nice vision. So it's very good. And what about the PC200 for PCNL? In a regular PCNL with a rigid nephroscope, up to half of cases, as per this study led by Professor Sarika, up to half of cases, 50%, you cannot see the whole kidney, the whole pilocalyceal system, because rigid instruments don't allow you to. And this is important because this impacts the stone-free status of patients. In a case like this, it's impossible to assess the whole stone with a single tract and a rigid nephroscope. Of course, you have combined surgery as an option, but it's time-consuming. Very nice option, but it's time-consuming, and you normally need another surgeon who knows what they're doing. You can also do a multi-tract PCNL, but we also know that the number of tracts are an independent risk factor of bleeding. So a very nice option that we recently have is the flexible cystoscopes, like the PC200, used as flexible nephroscopes. And also, in this one in particular, thanks to the suction, we got all the advantages that suction in PCNL have. The reduction of complications, especially sepsis, and the improvement of stone-free rates. So I'm going to present a case that I did last week. It was a PCNL fully 100% performed with a PC200. So the case was an 80-year-old female referred to our center for PCNL. She had no known drug allergy. She was a non-smoker, and she was very comorbid. She got Alzheimer's, she got high blood pressure, type 2 diabetes, and permanent UTIs with her stones. She was referred us to do a PCNL on a 70 millimeters left kidney lower pole stone, 1,100 Hanfield units. So when we assessed the case, this is her CT scan. She's a very short lady. And if you look at the stone, she was referred to us because the angle for flexible ureteroscopy was not very easy. And when we assessed for PCNL, if we wanted to do a papillary puncture, it was all in the middle of the iliac crest. So it was not very convenient. This is the image of the eye of the C-arm X-ray. And it is right in the way of the iliac crest. So if you have a look at the calyx, the papilla is right below. So no way in my hands that I could do a papillary puncture. So I thought maybe I could reach the mid-pole and use the PC200, the flexible cystoscope, as a nephroscope and treat the stone. I could have done it through one of the two upper poles, but the lower one had also a narrowish infundibulum, and I didn't want to harm it, moving too much the sheath or. And the upper pole, when I checked with the ultrasound, because I always do, was in the middle of the pleura, was in the way, so I didn't want to harm. So I decided mid-pole and going with the flexible cystoscopes by PUSEN with suction. When I do supine position 80% of the cases. This is how I position the patient, Valdivia Galdacao. If I'm going to do not an upper pole puncture, I only mark the 12th rib. If I do upper pole, I mark 11th and 12th rib. This is the configuration of my theater. I always have X-ray and ultrasound. I always check with ultrasound when I'm doing supine. And I have ready my normal screen and the PUSEN one, always. I puncture at 0 degrees, but if I don't get, I calculate everything with the CT scan and the II image. But if I don't get it right at the first shot, I use this technique of 30 degrees towards head. So this is how I did the puncture. I got bloody urine, but I expected it because of the UTIs. I got the wire, hydrophilic wire down. I did always a little cut and make sure the wire is free. Then an 8 French dilator, this without X-ray. Then I exchanged the wire by a Lunderquist wire, which is a wire that is normally, I got it from my fellowship with Professor Liatsikos. It's normally in the catalog for interventional radiology, and it's very, very stiff. Then I get a 10 French wire exchanger. My colleague gets the wire through the urethra, and she secures it with a clip, and we got the universal access. I remove the inner dilator, the 8 French one. This wire, I can leave it's secured through the urethra, and it's very, very stiff, so I'm sure it's not going to move. And then I get the second wire as a safety guide wire, and I clip both of them outside my channel. And I dilate, in this case, I dilated one shot with Amplats, 22 French. So once in, I got in with the PC200 cystoscopes by PUSEN with direct in-scope suction. I didn't get the sheath too much in because otherwise my maneuverability was very affected. So I just got it in the tip. And I located the stone. The angle was not very comfortable, but we know in most of cases it's not. So we just have to adapt. I found the stone right in there. That's the PJ. The fiber, I had to go a little bit back to load the fiber, and I started lasering. The image on the right does not match exactly the image on the left, but roughly. And if you see, the angle was what it was, but I could do it. And if you see, there's not much powder because you don't see it on the image because it does not match. But when I saw a little bit of powder, I just used the suction. So my vision was very good during the whole procedure. And this is on the first image is the just first time I saw the stone. And second one is when with this strategy, it would have been impossible without this new device, impossible. And in just 53 minutes, because thanks to the enhanced vision and thanks to the cystoscope, nephroscope that led me all the angles I wanted, I didn't have to go in, out. I was just lasering the stone the whole procedure. So 53 minutes for removing the whole stone. This is my team. And to conclude my intervention today, my lecture, the PC200 cysto and nephrovideoscope with direct in-scope suction by PUSEN It's a very, very promising technology. It has many advantages for cystoscopy. It may be, if it's not already, a game changer for PCNL, though data is needed. It has just been released in the market and we need to assess it with studies and numbers. Thank you all so much, Shishe, for your attention. And I let the word to Bhaskar.
Thank you, Begona. That was wonderful. And the case was very, very good. You know, the suction, because now we understand it better, do you think for cystoscopy, for example, bladder tumor, when you do tula, you know, you've got a bit of debris, you can suck that out. Even bladder stone, can you do it under local anesthetic? I mean, the potential for any cystoscopic procedure where you can use suction to help your life decrease the discomfort is quite a lot, isn't it?
100%. I think that's the future. If not the
And we have
present.
started, yeah. So, I mean, we have started doing exactly the same. So when you do bladder tumor now, if you've got suction, you can suck out the debris that form over the bladder tumor ablation. You can carry on. You can do local anesthetic procedures. So I think personally that this will really add a big dimension to cystoscopy. It really would be very helpful. Are you using it for cystoscopies now, Begona?
By now, I have it in my theater only. When I'm doing a PCNL, now I open it, I insert the stent, everything, the stent, the catheter, everything, and I have it ready for above. This case, I didn't
Inspection.
think I was going to complete it 100% with it, but in the end, I didn't need any other scope. But in
Okay.
my cystoscopy clinic, my managers are still not. Maybe in the near future, but not
Yeah,
yet.
I understand. And sometimes you have to balance the cost versus the usability. So we use it, not for every case, but we use it for, as I said, you know, if there's a lot of debris or dust, for bladder tumor, for local anesthetic bladder stones. So, and gradually, I think the indications will increase. Thank you so much once again for an excellent presentation, Begona.
Thank you
With
to
that,
you.
thank you. With that, I'll move to our next speaker, Angus, who is going to talk about the future of ureteroscopes in terms of both the single-use scopes as well as the smaller scopes. Angus, over to you.
Thank you, Bhaskar, and thank you to Cassia and PUSEN for having me. My screen is frozen. Can somebody see it?
Not yet, Angus. It's coming now.
Coming now.
Yeah, we can see it now.
Yes, excellent. That's great. So I've been asked to talk today about our smaller ureteroscopes, the future of urology. And I've also wanted to add whether single-use scopes are the future. I think that's very important. They are somewhat linked. Start my PowerPoint again. Apologies about this.
No problem. It's okay. While you fix the screen, Angus, I just wanted to check if Vincent and Begona are around. What do they think about the smaller scopes? Do they use it in their practice? Because I certainly use it in my practice now. And probably, if there's one game changer for endourology, where the stenting rates can be reduced, etc., it is small scopes. I don't know, Vincent, what do you think? I know Angus is going to talk all about it, but what is your practice generally?
I fully agree. I think the smaller the better. When a patient is every time, I never pre-stent my patients without having a try. When I insert first the guide wire and I see that the ureteral orifice opens well, then I tend to try it in general with a reusable flexible ureteroscope, which is a little bit bigger. When it seems small, then I'm going for or a fiber optic reusable flexible ureteroscope that is in general smaller, or when the image is more important for some cases, then I'm going for a disposable small flexible ureteroscope.
Smaller scopes.
And I use the smallest on the market, the smallest as possible.
And
the most important thing is that they are robust. But I think if they are robust, if they don't break and they are small, then it's okay. And whether the working channel is 3.6 French or 3 French, I think this is less important. Or that the image quality is maybe a little bit less good, I think it's all less important. I prefer really small.
The size is important. Yeah. And Begona, same for you?
100% agree. I mean, our mission is getting the stone out without scratching anything, without doing any harm.
Yeah.
And nowadays, with all this technological momentum, ureters are in risk.
Yeah, agreed.
So
Agreed.
I think that the less we harm, of course, the better. And we have to use every tool we have.
Yeah.
To get
Angus,
quality.
don't worry. Angus, if it's not working, can I suggest something?
Yes.
Please email it to Cassie and myself.
Sure.
I will start with my presentation and then we can forward it as you talk. So please email it to Cassie and myself for now. And I'll start with my presentation if that's okay.
Peace. Sorry about this.
No, don't worry. It's okay. These things happen. Technology has its moments, so no problem at all. Sorry, I'm just going to stop sharing just now. So I'm going to talk about the role of suction in urology, and that is suction via the scope and suction via the sheath. And I think if there's one thing that is game-changing in this field, it is the suction technology. These are my relevant conflicts. So let's talk about innovation in ureteroscopy. This is the time trend of ureteroscopy from 1954 onwards. And do you know what is the last most important addition to this? What the most important discovery? It is the suction through the ureteroscope. That's the last thing that has been added on ureteroscopy in terms of innovation. So you can have suction via the scope, you can have suction via the sheath, and of course, we need to check about the cost effectiveness as well. Now I'm going to talk about the suction ureteroscope and what the mechanics of this is. So here you can see me. This is the PUSEN suction 7.5 ureteroscope. You've got the built-in adapter for laser. You've got the suction portal, which you can move, and then the suction button that you have, which is controlled by the fingertip, which is really quite intuitive because the whole thing is really very, very, anatomically just very, very nice. The advantage, of course, apart from whatever has been mentioned with portability, sterility, visual quality, and so on, you can also record it. It's the integrated suction function in these. What does it mean? If you look, I'm just pressing my forefinger like this, and you can see the suction happening. So that's really very intuitive, very much in your control. And that is what I like about it. Now, I'm going to share some cases with you. So the first case was a female patient, 2.1 centimeter stone, recurrent UTIs, and you wanted to reduce operative time, intrarenal pressure, and to try and break the stone. Now here we are. I've got the scope, and as you can see, while I'm fragmenting it, I'm sucking it, and you can see the view is maintained because normally when you fragment stones, the view goes because of all the debris, and when you're sucking it a little bit, then you can see the view is maintained. You're not having to stop and start. So that is the first advantage. The second advantage, she's got recurrent UTIs. She's high risk of infection. By sucking intermittently, you keep the intrarenal pressure low. Vincent has already said it's important. So we keep the pressure low, which means there's risk of infection and sepsis afterwards. And of course, you're lasering. You can go on for a lot longer. So temperature is important. And with intermittent suction, the temperature is also minimized. So it is helpful for vision. You can go for a bit longer and you can keep the pressure low and you can keep the temperature low. The second case is again a male patient with mid-ureteric stenosis with a low pole stone. And the idea here is to overcome the stricture, minimize the operative time, and helps with suction, okay? So this is the first, you can see it's a very, very tight ureter. I do an endopilotomy. So for this, I normally use 0.1 joule and about 5 to 10 hertz, depending on what you're comfortable with, to open it. Again, this is a ureteric stricture. The patient has been referred. So I want to just get enough to get the scope in. That is what we do. So do an endopilotomy and get the scope in. Okay. Once the scope is in, you can see there's a lot of debris. The kidney is hydronephrotic, a lot of dust and debris in the kidney. What do? We use the suction button and you can aspirate it, but it is difficult, as we know, to aspirate through a syringe. Use the suction button to aspirate all the dust and debris from the kidney. Okay. Now the stone is in a difficult lower pool. When you do suction, you also bring the lower pole closer to you. You'll see it here. I'm doing intermittent suction and the stone is also coming closer to you. Normally you struggle with a lower pole stone in a difficult kidney, but because you're sucking, the stone is moving close to the laser. So that's also an advantage in the lower pole in this kind of cases where the stone is coming to you because of the suction. Now, the important thing is to note that the suction doesn't allow the fragments to be removed. It allows the dust and the small particles to be removed. So if you want to remove fragments, then you'll be disappointed because it doesn't do fragment removal. Now, good vision. What was my initial impression? We could go for a lot longer without worrying about temperature and pressure, and the suction helped in the lower pole because a stone could come to you. Now, we have looked at the PUSEN suction scope. We've just recently published it from 5 European centers and Asian center in Hong Kong. Prospective consecutive patients, 57 patients with a stone volume of 480 millimeter cube. The mean diameter was about 18 millimeters and almost 60% with multiple stones. And the suction, when we asked the physicians, urologists, suction was meant to be helpful in at least 95% of cases, most of the cases, let's say. So was access sheath used? Yes. And was suction helpful? Quite a lot of them said yes, suction was helpful. Now, when you look at the results, the stent rates were about 84%. Remember, these were big stones, one minor bleeding, no other complication post-op, none apart from one minor bleeding. Stone-free rate, good. The stone size larger than 2 centimeter, again, good stone-free rate. And we followed them up for 5 weeks. So we then asked about the quality parameters of the scope. 1 was not good and 5 was very good. Most of them scored between 4 and 5. So again, they're very happy with the quality of the scope. We asked about the compared to pre-existing scope, how is it? Again, most of them is rated between 4 and 5, some 3, which is equivalent, let's say. And then we asked them about whether you would want to use them. Almost all of them said yes, they would want to use them. Now, coming to the next, this is again a case where we're using a suction scope. I'm starting from halfway because I just wanted to show you at the end how it works. So here we are using constant lasering. You know, with lasering, the temperature can go up, but because I'm doing intermittent suction, I'm not worried. So I can keep going. I'm not saying you don't have to worry, but you can worry less when you're using intermittent suction because you're sucking out that warm fluid. Okay, and in the end, this is what you get. You got fine dust, you got tiny bit that I can remove. You can see how small it is. And I'm using a basket to just remove the smallest fragment there. And the rest of it is about maybe 1 millimeter or less fragments. And that can be removed. So what is the impression? I think the suction scope is very good with good maneuverability, visibility, suction quality. And I think in future, large operative channels might help, probably. And we'll see some evidence of that towards the end of my presentation. Now, what about suction sheath? In this case, we're using a suction sheath with a TFL laser. Now, let's see this case, 2 centimeter stone in the bottom and the lower pole. Looks like a hard stone. I'm breaking the stones. The problem with large stones is when you break, you dust, you leave a stent, you think the fragments will all go away or the dust will go away. It doesn't always happen. What happens is you're left with residual fragments or dust that then regrows. So stone recurrence is a big problem. With suction access sheath, and you will see that in a minute, what you can do is you can put the sheath where the stone is, guide it through the endoscope, and then you can suck out the fragments. So here you can see my sheath is exactly where the fragments are, and I'm sucking out the fragments. So the suction is attached to the distal end, to the surgeon's hand, to the surgeon end, and you can see the fragments. You go in and out, the fragments come out and go out to the side channel. Go back in again and repeat the same process. When you do that, you literally take out all the fragments out. And this is the beauty of using a suction sheath. So you keep going in and out and you can see the fragments coming out. Okay. And this to me is a game changer. At the end, if you see, once all the fragments come out and you'll see the pictures before and after, 2 centimeter stone, not pre-stented, single setting, stone free on a CT scan. And that is the beauty. This was a pediatric patient that we wanted to do PCNL, but because the stent had migrated up, we ended up putting the stent down. Because we pulled the stent down, we thought, let's just carry on and see. And we ended up doing ureteroscopy laser fragmentation. Big stone, 2 centimeter stone again in a pediatric patient. I'm just, in the interest of time, I'm going to move forward. You can see it's a soft stone, but original plan PCNL, we did a ureteroscopy, and you'll see how suction is helping the fragments to come out. So you attack the suction and all the dust and debris you're sucking out, normally what you would have needed a PCNL. Now, with a normal access sheath, this wouldn't happen. You would have to keep going back and forth, removing bit by bit. Here with a suction sheath, you attach the suction, and a lot of it you can just see flowing out. And in the end, you will see that the patient, the pediatric patient, is completely stone-free. And this is, again, the beauty. You've got a little bit of, mucoid debris left, which I'm taking out of the basket, but that's it. Apart from that, there was nothing else. So to my mind, again, in some cases where you might have, so this is the end picture where you see there's, maybe a little bit of dust, tiny amount, but rest of it is completely stone-free. So there are various ways of applying suction. You can apply it through the sheath, via the scope, via catheters. What is the evidence of suction access sheath? This paper just recently published looked at almost 400 patients with quite large stone burden, a lot of them between 1 and 2 centimeter or over 2 centimeter, a CT scan before and within 30 days. Laser was used, combination, but TFL in about 46%. Now, there was 1 blood transfusion, 3% low-grade fever, but 0 sepsis. This is for large stones in almost 400 patients, 0 sepsis. Low-grade ureteric injury in 2%, not needing any major intervention apart from stenting. Stone-free rate, if you defined it as 0 fragments on CT scan, 58%. If you defined it as 2 millimeter fragment, 97%. 97% stone-free if you had 2 millimeter as a cutoff for stone-free. Very good results. So what do I think? Again, this is a comparative study between PCL and suction sheath, and actually it showed no difference in stone-free rate for comparable patients at 2 months. Here they use suction sheath with scope again for 900 patients. And again, the results were very good. Stone-free rate almost 90%, and injury, fever, etc. was low. 0 sepsis and ureteral injury in this paper. Cystoscope, Begona has already covered, and I'll just show you a quick video of a cystoscope that we used. Again, you can see a lot of dust and debris in the bladder. We are sucking it all out, and in the end, you'll see normally what would have taken a lot longer, you can see. So good use in cystoscope as well. Now, there is something, what is the future of endourology? I think there's a lot of advantage of suction in terms of pressure, temperature, visualization, probably pushing procedural limits, although we have to be careful, reducing complications like sepsis and bleeding, and better stone-free rate. So what is the disadvantage then? I think there is a bit more complexity. You have a suction tube in addition to what you're used to. The suction parameters, we don't fully understand. There is increased irrigation usage. You do use a lot more irrigation for this. So I think the future will be small scope, which is least invasive. You dust it, suck it out, temperature, pressure monitoring, maybe some AI to predict the outcome with no recurrence. That is what we'd want. So what is the future for scope suction? So we now have got a 5.1 French working channel for suction with a 9.2 scope. This is how it works. So you can see as you suck, you can then suck out the tiny dust, which is much better in terms of suction because of the slightly better working channel. That's the idea. I've got a short video clip from last weekend, but I didn't get a chance to scan the CT scan, but you'll see on the left side of the screen is big hard stone in a single kidney. On the right side is a 3 centimeter stone. The advantage of using a bigger channel is when you're sucking, the vision gets maintained, the small soft debris gets washed out, so you can actually operate for a lot longer, which I think is an advantage. In both cases, you will see that the vision is maintained a lot better, especially in the right side of your screen. So this was a 3 centimeter stone. I kept on going without having to really stop that much, just by using suction from time to time. And I think that will be a good game changer. Now, again, to warn you, I'm not saying that it'll suck fragments out. I don't think so. But the dust less than 1 millimeter or dust and fragments less than 1 millimeter, a half a millimeter, it'll suck out. You have to be careful how you use it, but I think this will be a game changer, especially for big stones where you have got to go for a lot longer. And then as you use pop dusting again, you can use suction in between to try and clear up that dust. So with that, I'm going to conclude and say, I think suction will be the future. This is the results of a recent meta-analysis we have just published with 16 studies, and suction was shown to improve stone throw rate, reduce both overall and infectious complication rate, and length of stay. So thank you once again. And now we had the knowledge and technology, and we have merged it. And one of the technological advances, of course, is suction. I'm going to end my presentation here, and we are going to share the presentation of Angus. Cassia, do you have it? Do you want to share it?
Yes, I can share it.
Thank you.
Thank you,
Angus, while we wait, I think for me, there's a combination of single-use scope, suction, and better monitoring. If you bring these two together, that's the future of endourology. So, Angus, over to you.
I think without a doubt, you've just done my presentation for me, Bhaskar. But I will try to do another 15-minute talk about this and maybe go into a bit more details about it. So, apologies for the previous technology issues, but we have it now. So Cassie, you want to go to the next page, please? And as Bhaskar mentioned, I will be talking about the single-use and smaller ureteroscopes and why they are the future of urology. This is my conflict of interest. Next page, please, Cassie. So I just want to start by basically going through, at the moment, what's really out there in the commercial world in terms of flexible ureteroscopes. A bit of a quick history lesson, really. I won't spend very long on this. Again, as we all know, fiber optic reusable flexible ureteroscopes is what we've had first, and it's been in the market since the 1980s. It's been for that long. Digital reusable scopes were introduced to us in the commercial market in about 2006. Firstly, the scope was DURD Invisio by a company called ACMI, which is now acquired by Olympus. And then more recently, we have the single-use digital flexible ureteroscopes. The first one being by Boston Scientific in 2015, the Liverview, and then PUSEN shortly after in 2016. So you just press once, please. And as you can see here, I just thought, given this is a PUSEN-sponsored webinar, I thought it'd be amiss of me to not show the first ever generation of the PUSEN scope in 2016. The top one is the one they have the latest model now, and the bottom one is the one in 2016. You can see that things have moved on since. So, just want to really talk about the advantages and disadvantages between the fiber optic and digital scopes. Now, obviously, the biggest difference is how images are transmitted between these two different types of scopes. With digital scopes, you essentially have a camera chip with a light source at the tip, and these images are transferred digitally to a screen, whereas a fiber optic is all analog images through the coherent fiber optic fiber ordering to a camera. So digital scopes, there's no doubt, give a much superior imaging quality. It can cover much better pixels, and because it requires less cabling and camera heads, there's advantage of the weight, which leads to a better ergonomics in using digital scopes as well. Now, the reason why fiber optic scopes, despite these advantages from digital scopes, still remains, around the market for so long is that several reasons. Number one, they cost a lot less comparatively. And number two, until very recently, fiber optic scopes still maintains a significant size advantages to digital scopes. This is because despite needing much less cable running through the actual sheath of the scope itself, a digital scope still needs to house the camera chip at the tip. And until recently, this has been hampered by bottleneck of technology and miniaturization. And what you actually commonly find is that the tip of the digital scopes is actually slightly bigger than the size sheath of the scope itself. Now, this is just some comments. The reusable scopes we have in the market. The top ones are ones by Olympus and ones by Storz. And on the fiber optic side, you can see that they are all fairly small, less than 8 French, with a much smaller distal tip. Whilst on the digital side, they are unfortunately cannot get below 8 French, and notably both of them has a similar working channel sizes. So, what are the evidence for using smaller ureteroscopes? And I think we've all covered this already, and we probably know it off by instinct really as endourologists is that smaller ureteroscopes will give us a better chance of access. We all know that our beloved ureter is a very delicate and a very small bit of human body, and we all like to take care of it very nicely. And this paper by Bagley, PUSEN and Bagley in 2005 is really the seminal paper where we approach really the access rate failure for different size of scopes. As you can see here, if you have 7.4 French scopes, the risk of failure access is only about 1%, going all the way up to even 9 French scope, which reported at the time 37%. So quite a significant difference. Another single center paper by Hrabowski later on compared different access rates between digital scopes and a fiber optic scopes. Again, with the fiber optic scope being a 7.5 French by Flex X2 is reported as 1.4%, with a much bigger first generation of limited scope, the 9.9 French scope. The failed access rate is 6.5%. These are patients who have no prior stenting and no active ureteral pathologies. So this is a paper from a group from Germany by Bach. Again, this is a randomized controlled trial where they've looked at using different comparing fiber optic versus digital scopes in form FIRS for kidney stones. And really, the important thing to highlight is that in the digital FIRS group, they had a higher requirement for using access sheath. They found there's a higher rate of postoperative stenting. And certainly in the digital scope, with the bigger scopes, they reported 2 cases out of 77 where they were related to ureteric perforations while they were none in the fiber optic. And again, as Vincent and Bhaskar mentioned, one of the main benefits of having a small scope, despite, other than just an access, is that in our practice, and certainly mine, we tend to find that there's much significantly less need for stenting as well. And also, particularly in an unstented patient, which really is the norm, particularly in UK practice, we do not routinely pre-stent our patients. Get access much easier, and the risk of causing injury seems to be much less with a small scope as well. Now this moves nicely on to using smaller ureteroscopes with ureteral access sheath, intravenous pressure, and irrigation. Again, Vincent already covered that quite a lot, so I won't go through this again massive amount. But again, this is a nice paper from Senna and Trexer, essentially suggesting that the larger the scope, the larger access sheath you will need if you use one. And again, this is fairly common sense. And as Vincent already mentioned, you want a ratio about 0.75 between the scope and the access sheath size. For me, that in practice translates to about 2 to 3 French difference between the scope size and the internal size of the access sheath. So in my practice, if I'm using a 7.5 French scope, I would normally use a 10-12 access sheath. Or if I'm using whether I'm using a digital reader of scopes, the UIV3, which is about 8.4 French, I would use 11-13 or sometimes 12-14 for extended patients. Now you can, in theory, still use a smaller access sheath for a bigger size scopes, but you get a significant drop in the irrigation flow, which leads to a worsening pressure. And so this is top demonstrated. We really don't want that. And with the smaller scopes, now there may be other reasons. You may want to use a bigger access sheath size, and whether it's a risk of infection, or you just want to maximize the irrigation and minimize the pressure. But regardless of what size you use, a small scope simply allows it to happen. And even if you're not using access sheath, the outflow from between the area between scopes and the ureter will simply also be bigger, smaller scope, so you get a better outflow. Please. Hello.
So next slide, please.
Are you here with us?
Am I back on?
Yes,
Yeah,
you are back.
You're here.
That's great. Sorry, my computer just had a blink just now. So Carol, so hopefully I would have convinced you now that a smaller scope is better, but does that mean that we have to stick to the smaller fiber optic scope? Well, that has been a conundrum until single-use scopes came along. But like I said, when it first came out, the single-use scopes, particularly the Boston Scientific 2015, they were about 9 French, so they're no less smaller than the existing reusable digital scopes. But when 2020 PUSEN first came out with really the world's first 7.5 scopes, and things have exploded since then. I think all the panel would agree that 7.5 French single-use scope is now really the standard that we come to expect. The weight and ergonomic side, it's pretty much lighter than both the digital and the fiber optic scopes. That's an advantage of one single-use scopes. And the imaging quality, also, again, we've seen quite a few images already today from our various speakers. Hopefully can convince you that they are just as good, if not probably better than now even some of the digital scopes, and certainly better than the fiber optic scopes. So what are the additional advantages of using a single-use scope? Firstly, these scopes are all come in a sterile packet, so there's no cross-contamination risk. Again, as you probably know, most of the reusable scopes cannot be sterilized, and there are increasing concerns about cross-contamination risk with multi-resistant bugs. These scopes are readily available off the shelf, so when you need one, they are always there, and as long as your department stocks them well. I'm sure all of us have come across times where in the middle of operation, or when we're just about to do our next case, we ask for reusable scopes, only to be told that they are being processed, or there's a delay in the progress and cannot proceed. These reusable scopes are very delicate, and they are at high risk of breakage, particularly in cases which are difficult, or whether it's a large stone size or you have a significant pelvic angle, or if you have a trainee that you're training who will be using these very expensive reusable scopes. With a single-use scopes, that's not a problem. Use once, throw it away. Even if it's broken, you're not going to cry about it, and the department isn't going to put your head down for possible more financial damage. Now, what are the disadvantages of single-use scopes? That's certainly an environmental impact. We are throwing away an amount of plastics, camera chip, as well as the wirings and cables, or every time you use one of these scopes. So there is a materials impact with that side. From a carbon footprint perspective, however, there has been studies that looked at the carbon footprint impact comparing the reusables and the single-use. And if you also take into consideration of the reprocessing and also the amount of chemicals that's required to reprocess the reusable scopes, the carbon footprint actually is about pretty much the same between single-use and reusable scopes. Now, what about financial cost? Initially, when these single-use scopes came out, they were very expensive, particularly Boston Scientific came on a review. At least in the UK, they were about £1,000 for single use, where in the public health system, it is very hard to justify that cost. Since then, the market has again flourished significantly, and the cost has substantially come down. And certainly in my department, we now run a hybrid model where we have both a reusable available as well as, and certainly in difficult cases, or where cases we need, or where it anticipates difficult access, or we cannot get access with the reusable scope due to the size, or we can with a single-use scope, we certainly use it. That has a different additional benefit of saving the patient to come back stented on a day, which again is added saving cost in terms of the waiting list itself as well. So I think it breaks even then well with a hybrid model. Next, please, Cassie. Now, are there any drawbacks with using a smaller ureteroscope? Well, one may particularly think that with a smaller scope, you would expect a smaller working channel, but actually, certainly when it comes up to looking down to 7.5 French scopes compared to other existing reusable models, bigger models, all of them have a working channel size of 3.6 French. So that doesn't seem to be the problem here. Now, Bhaskar has already shown in PUSEN's new 9.2 French this scope, which has a 5.1 French working channel for the in-scope suction. So this will be a balance in cases where you want to maximize the suction, where you may want to sacrifice the scope size. But all in all, at least down to about 7.5 smaller ureteroscopes, they're necessarily complex channel size. Now, there are other companies out there which have made even smaller single-use flexible ureteroscopes where they had to reduce the working channel size down to about 3.2 French. Whether this has any significant impact in terms of the flow, irrigation, intravenous pressure remains to be seen. This is also new. Now, are these smaller scopes more fragile? May think so, but actually, if you look at studies comparing the older fiber optic 7.5 French scopes compared to digital scopes, they don't seem to break any more. So that doesn't seem to be the case. Certainly, if you're using single-use scopes, that would matter. There have been some initial concerns about whether these small scopes would have a slight less rigidity, which may translate to worsening performance of passive deflection, or whether they lose any torque at all. Again, no studies have really looked into these specifically, and I think I'll be interested to hear what the rest of the panel has to say. But in my view, I think this is more down to the individual mix, and certainly in my experience of using various models of smaller single-use 7.5 scopes, they seem to perform very well in both the applied torque and also the passive deflection as well. So all in all, I don't think there's any significant drawback in using a smaller scope. And hopefully, in conclusion, are smaller ureteroscopes the future of endourology? I think most certainly with improved, a better chance of getting access, smaller needs of using feeding to stent, as well as a reduction in intravenous pressure and improvement in irrigation outflow. There's certainly no reason why we should be using bigger scopes that would actually maximize the in-scope suction in French. And our single-use ureteroscopes, the future of urology, I would say increasingly so. They really the advantage of both the old model of fiber optic and digital scopes, with very, very limited. So that's the end of my talk. Thank you very much. Apologies again for the technology problems.
No problem at all, Angus. You did very well despite the interruptions, and it was excellent. So I think one thing we can agree that small scopes will be the future. Single-use scopes, depending on your healthcare setup, probably may not be for all. So we don't use it for every patient, but we use it for about a third of our patients. And if you have the option of suction, my question would be why not? If somebody needs to really convince me why I shouldn't have it rather than why I should have it. It should be default. You don't have to use it every time. You don't have to use it in every case, but if it's there, then you can use it and you have the option of having it for every case. So I'll ask you something, Vincent. One single thing that you can pick out from where you see the future of endourology going, what would be that one thing? And I'll ask each panel member.
Well, I think the technology that includes temperature sensors, pressure sensors, and devices that control the pressure and maybe the temperature during intervention and gives you kind of an alarm when you're exceeding specific thresholds. I think
so make it safer. Make it safer, basically. Yeah, okay.
But also I think that's, yeah, and of course, I'm a big fan of these things should come with aspiration.
Yeah.
And I'm convinced that aspiration will improve our stone-free rates.
Yeah, well, I think so as well. And some form of aspiration, agreed. What about you, Angus? What do you think? If you had to pick out.
I would broadly agree with Vincent, but just to say something different rather than just saying I say the same. I think the role of AI and really predictive models on really what would be the most appropriate route in management of stone with all the big data. For example, with a big AI model, we can use to predict sepsis risk, which modality, ureteroscopy, entering the combined procedures, PCNLs would give, offer the patient best chance of stone clearance. And a lot of it would, as what Vincent says as well, using all these integrated, smart, sensing functions, again, to really maximize the best patient outcome and risk.
So decision-making predictive tools, something that helps clinicians, everybody. Agreed, yeah. And Begona, same question again. I know they have taken away but what is there anything else, or you agree?
Yeah, I think the issue nowadays, the issue is very simple. We have amazing technologies, but we know in endourology time matters a lot. And we want to be fast and safe at the same time, getting the most out of the technologies, but we cannot get the most out of them because we don't know if we're safe. So everything, I think that what you all have said, if we have a temperature sensor, we have a pressure sensor, and you just know when you have to stop, you will go nicely to your limit safely.
Yeah. I agree with all of that. I just want to make two other things very clear to all our listeners. The first one is, make sure your suction is good enough, because sometimes people blame the scope or the sheath. If the suction is not good enough, you will not get the suction. So it's very important to make sure that the suction that you have is good enough. The second thing to say is, some people have asked, you use scope or sheath. I don't think they're doing the same job. So during the procedure, use the scope suction, because you have got control single-handedly. You don't need people to help you. And you can see how much the system is decompressing. You can go on making it safe suction. But after the procedure, to suck out the fragments will not come from the scope. Then you can use a sheath suction. You can use the same tubing. You don't need two tubings. Just move it from the scope to the sheath and get the sheath, then remove the fragments. So when people ask which one, I don't think that's a fair question. I think, how can we combine the best of the two is what I would say. So it's like a marriage. You don't need one or the other partners. You need both the partners, and then you get the best of your marriage. With that, thank you so much, all of you. And to Cassia, Wendy, and the whole team of PUSEN, thank you once again.
Thank you, Professor Somani. Thank you, all the faculty members, Dr. Martinez, Dr. De Coninck, and Dr. Luk. Thank you for sharing your expertise and knowledge. And thank you for all the participants for being here with us.
Bye.
Have a good day.
Too.